Chairman, thank you for the honor and privilege to present my point of view as an internist. So this is my conflict of interest. And my outline will be, does metabolic surgery will improve diabetes control better than medical treatment in my patient? Can I predict the long-term remission rate for my patient? Can I predict the long-term relapse rate of diabetes for my patient? And can metabolic surgery prevent mortality in my patient? So I will start with the first question. Does metabolic surgery will improve diabetes control better than medical treatment in my patient? So we know that from all this very interesting and very important study that the remission of diabetes by metabolic surgery is around 50%. And we know from this IDMSS Congress and the work from Cummings and Cohen that showed us that after meta-analysis, the impact of bariatric surgery on the reduction of hemoglobin A1C and remission of diabetes is not related to BMI, and even lower BMI can cause remission and reduction in hemoglobin A1C. And also, this Stampede study that prospectively examined this question also showed the same results, that bariatric surgery or metabolic surgery, no matter what is the BMI, is effective in remission and reduction in hemoglobin A1C and fasting plasma glucose. This week, another meta-analysis was published in obesity surgery with other studies that show the same direction. So metabolic surgery can cause remission of diabetes, can reduce hemoglobin A1C and fasting plasma glucose very efficiently compared to medical treatment. So we know, and the answer is yes, metabolic surgeries are better than the best medical treatment, and this algorithm is very useful for us because even those patients with BMI between 30 and 35, if they are not controlled by best medical treatment, really recommend to have metabolic surgery. And we see that this notion or this perspective is getting into the guidelines of the internists. Okay, so in the ADA guidelines 2018, we can see that they recommend that those diabetic patients that didn't get to the target of hemoglobin A1C and their BMI is between 30 to 35, metabolic surgery is recommended. And very recently, the ESD and ADA consensus statement, which is a very good one, also recommend that those patients that have obesity and does not get to the target of hemoglobin A1C should consider to have metabolic surgery. So the answer to the first question is yes, metabolic surgery is better than medical treatment. So the second question is, can I predict the long-term remission rates for my patient? So this is very important because the patients come to me and really expect that the diabetes will vanish, that they will be cured from diabetes. And this is wrong. And we should have a tool to predict what are the success rates in remission. So I want to present again our study that was just published. We took from Clalit Health Fund database from this above 13,000 operated patients. We had 16% of diabetic patients, and we followed retrospectively for 2 and 5 years. And we want to correlate the scoring system by the diagram that was published by Steele to what we called AD diagram, advanced diagram. So we add to the diagram two other categories of number of anti-diabetic drugs and diabetic duration. And the aim of the study was to see, to predict the long term, not just the diagram predict 1 year after Roux-en-Y, so we want to predict the long term, the 5 years of 3 other surgery of Roux-en-Y, sleeve and band. So this is the basic characteristics, and you can see that if we compare the DR, meaning the remission, diabetic remission, to non-diabetic remission, all the category of the edge diagram were significantly better for those who remit the diabetes. And we created such a map, meaning if you take the diagram score, you can see that you have overlap of those, of the score of those that did not remit and those who remit. This part is the positive predictive value, and the pink part is the negative predictive value, and there is overlap. So the diagram, especially for the Roux-en-Y, wasn't so specific and sensitive. Adding these two categories, new category, meaning the number of medication and the duration of diabetes, really improved remarkably the positive predictive value and the negative predictive value. So if you notice, the cutoff point is 11 points, and we wanted to see what are the predictors that really in the baseline predict that the patient will be below 11 points or will be will be in the category of diabetes remission. And as you can see, the predictor for remission in those patients was the procedure. The Roux-en-Y was much better. The BMI, the higher the BMI, the higher the chance to be included in diabetes remission group. The lower the fasting glucose and the lower the hemoglobin A1C, which is very important. And I stress this because the patient should get to the operation with the lower hemoglobin, the lowest hemoglobin A1C and fasting plasma glucose that we can achieve. And of course, the number of anti-diabetic medication, the lower the number, the higher the chance to remit diabetes. So, and then we created a scoring system. And again, you can see that if the patient have 0 to 5 point score, so the A diagram really point that 100% remission until, if you believe 100% in medicine. If the patient have 16 to 20%, 20 point of score, so the patient have very low. So in the ends of the score, the A diagram really add to Roux-en-Y gastric band bypass. So if the patient comes to me now, I can calculate the score and work with him and really predict what is the chance that he will remit the diabetes. And this is very important in the discussion. The third question is, can I predict the long-term relapse of diabetes for my patient? And this is also very important because we know that there is relapse of diabetes. And for this, again, very recently publication by our French group that was published in Diabetes Care. And what they did, again, they developed another scoring system, and they compared the risk for a 5-year relapse of diabetes to 5-year diabetes remission. And you can see that for this correlation or comparison, what is important is all the indices of weight loss. The indices of controlling glucose is not so important in predicting relapse. What is important is how much weight loss and which layer of weight loss. If you compare remission to non-remission, so the indices in the baseline of glucose is very important, much less the weight loss in the first year. So this is very important, and they created now a scoring system for relapse. And this scoring system take the baseline preoperative type 2 diabetes duration, the number of anti-diabetic medication, and the level of hemoglobin A1C in the baseline. But what was important in this score system that they also took indices of the first year, and this is the first year, the number of anti-medication in the first year that used, the fasting plasma glucose after the first year, the body weight lost from the baseline in the first year, and you see the numbers. Below 11, so those patients are predicted to remit the diabetes. So now we have two scoring systems, one for the prediction of remission and now for the prediction of relapse, and this is very important. The next question is, does metabolic surgery will prevent long-term progression to diabetes better than lifestyle and medical treatment in my patients? So we know that from the DPP, if you use lifestyle changes, you can prevent 60% of diabetes in pre-diabetes patients, and if you use metformin, you can prevent in 33% the development of diabetes in pre-diabetes patients compared to control. We also know from the SOS that if we are taking the pre-diabetes patient, and they define the pre-diabetes patient in fasting plasma glucose above 110, you can prevent in 80% the development of diabetes after all the operation. Now we again look on our cohort, and in our cohort 13% were pre-diabetes. Again, we did the same thing retrospectively. We wanted to see in comparing the three operations what will prevent the diabetes, and we can see that the band didn't prevent so much the diabetes compared to sleeve and Roux-en-Y. And sleeve here was the best operation in prevention of diabetes in those pre-diabetes patients. What was very interesting that we look on the first year weight loss, because we think that the first year weight loss is very important in prediction for long-term diabetes prevention. And we can see that no matter in which operation you had, if you lost more than 25% in the first year, you prevent your diabetes much better after 5 years control to those who lost only 15%. So weight loss in the first year is crucial in those patients. Next question. Can metabolic surgery prevent mortality in my patient? So we know from this, again, from the SOS study, the longest study, that yes, it can prevent fatal cardiovascular event and total cardiovascular event. Again, we published very recently in the JAMA our comparison of all the operation in Clalit Health Fund, and we compare 8,385 patients, surgical patients, to 25,155 control patients, which was chosen by very meticulous scoring, propensity score. And what we found that after 4.3 years mean of follow-up, that those who didn't have metabolic surgery had doubled the risk for total mortality, meaning that metabolic surgery or bariatric surgery reduced mortality by 50%. Tremendous effect. And we can see here the graph. This is just for the band and for the Roux-en-Y, and we have also the sleeve. Now, we ask ourselves, does the diabetic patient really benefit more than non-diabetic patient regarding mortality? And I show you this very preliminary data set because we didn't publish it yet, so don't photograph this. And what we saw that those patients, the red lines are the diabetic patients, are really those who benefit in the short term, meaning the 5 years follow-up from this operation. Because if you compare those diabetic patients that did the surgery to diabetic patients that did not have the surgery, so then you get the 50%. But if you compare those blue line of non-diabetic patients, you see that there is no benefit at least in these 4 years. So the metabolic surgery is really impact on mortality by the short term on the diabetic patient. But it's not surprised, because if you look on the SOS, you see for the whole cohort, the study really start, or the separation, the significant separation really start to appear after 11 years. So if you take the whole cohort, it takes more time. But if you take the diabetic patient, the metabolic patient is much faster, and it's occurring dramatically in these 4 years. Surprisingly enough, when we looked on the MACE event, we didn't see difference between those who operated and non-operated, meaning that the prevention of mortality was not, in our cohort, was not due mortality from cardiovascular event. Now, I'm sure that in this Congress we will hear a lot on the mechanism of metabolic surgery, and I'm sure, and I'm also convinced that all this wonderful mechanism that Rachel Bertram and Cummings put in this very nice paper is true. But I think that the effect of weight loss is a little bit neglected in the discussion on the metabolic surgery, and I think that the weight loss has crucial impact. It's not just my opinion. If you look on the SOS study, you can see that no matter what the operation they did, it is crucial to lose a lot of weight in order to prevent 2 years and 10 years diabetes. So they concluded this study by saying for long-term effect on glycemic control, weight loss is probably a major determinant. This is the long weight effect. So I want to propose to you a little bit different view on metabolic surgery. I think that in the beginning, the hormonal effect is very important. And I don't know how much time this hormonal effect is staying there. So according to Rubino, which I respect a lot, and Holst, which I respect a lot, the GLP-1 and POI are high for life. But I have a problem with this, because the patient come to me and say, look, I'm hungry again. And if the patient is hungry again, meaning that the balance between GLP-1, PYY, CCK, and ghrelin is changing. And I bring this very new article that showed that if you take those patients after Roux-en-Y that reduce their weight until the nadir and then regain weight, and then give them liraglutide 3.0 milligram, you can reduce again the weight almost to the same point of nadir. Meaning if you restore the level of GLP-1, you restore the weight loss. And if, in this point, they have a very high GLP-1, giving back GLP-1, I hypothesize, won't reduce their weight again. So we have to be very careful in stating, on my honest opinion, in stating that it's for life, the high level of GLP-1 and PYY. And I want to conclude by putting this in a cartoon. So if you look in the baseline years and effect of glycemic indices, so I'm sure that there is a hormonal change in the beginning, and we don't know how much time the effect of metabolic and hormonal change will take. I call this the honeymoon period. But as in life, there is marriage. And marriage is whole your life. And this, in part, I think the weight loss is very, very important. And I think this combination of metabolic and weight loss is very important. That's why I think we should call this the metabaric surgery, not just the metabolic surgery. And by this, I want to conclude and thank you for your attention. Thank you.